Hi, Dr. Kevin Windisch from Sparks Pediatric and Adolescent Medicine. Welcome to our video series for parents. Today we're going to talk about gastroesophageal reflux, which is something in the television is often called acid reflux. Specifically, we want to talk about it in infants. Please remember that these videos don't replace visits with your physician. If you have questions, we'll be happy to see you here in our office. You can call and schedule an appointment at area code 775-359-7111. Please remember we need to see your child. We can't just discuss this over the phone because these are complicated issues. So let's start with what is acid reflux. And I'm going to use the medical name for it, which is gastroesophageal reflux, or GERD. So what is GERD? In a nutshell, it's anytime acid from the stomach passes back into the esophagus, the tube that leads from the mouth to the stomach. This is more common in infants than it is in adults because they spend most of their time on their back instead of upright, so gravity doesn't work for them. And because of the fact that they consume most of their calories in the form of a liquid, so they need large volumes of food. And finally, because the distance between their esophagus and their mouth is very short, or between their mouth and their stomach is very short. Add to that the fact that the muscles that serve as a valve at the top of the stomach don't tighten up real well for certain infants, so that can make things worse. All infants to a point have reflux, but not all infants need medicine. In fact, most don't. For most, it's normal spitting up. So how do we make the diagnosis? How do we know who has reflux disease? Well, it's not so easy to tell sometimes. Certainly, if the child is irritable with the reflux, if the child is in pain from the reflux, if the child has uncontrolled asthma, if the child is aspirating into or inhaling into their lungs material that they've refluxed, if the child is not growing well because of the reflux, those are reasons to treat the child. If the child is happy and just spitting up, that's not a problem. Quite honestly, there are a number of children, one of my godsons in particular, who are just volcanic. They're volcanoes, and they spit up constantly. They outgrow it, and it's not a problem. So what do we do for these children who aren't growing, who are having asthma or allergies? And do we need to do more tests? Well, if things are uncontrolled and they don't respond to simple measures, we may wind up doing some tests where we give them some barium to swallow and get some x-rays just to make sure there's no scars or webs in their stomach or elsewhere in their upper GI tract. But most of the time it's a clinical study, a clinical exam. We look at the child, we get your history. Rarely, we may want to do a 24-hour pH probe, and for that, we'll take a small medical probe that's the size of a piece of spaghetti, and we pass it either through the nose or the mouth of the child, tape it in place and let the child eat, and then we just measure the amount of acid that's coming up into their esophagus. But 9 out of 10 cases, actually probably 99 out of 100 cases of children with reflux don't need that study. And in certain areas, such as where I live, Reno, that's just not something that's available to our patients. So how do we treat it? Well, we try to treat it without medicines if at all humanly possible. So the first thing we want to do is elevate the head of the bed. We want it to about 30 degrees. So this is 0 degrees, straight up and down is 90 degrees, halfway is 45 degrees, and half of that roughly is 30 degrees. That's roughly the same angle the child is sitting in their car seat or in their bouncy seat. So if you don't have an easy way of elevating the head of the bed, putting the car seat in the bed or the bouncy seat in the bed will often solve that problem for you. However, you can just elevate the head of the bed. How do we do that? You can place some books or some bricks under the head of the bed, down at the very bottom, right where it attaches to the ground, and that'll raise the bed up. Or you can buy a positioning wedge from any of a number of local pharmacies. They're just foam wedges that go underneath the mattress, and that'll elevate the head of the bed for you and for your child, and then you can put the sheets right over that. Try to keep the child upright for 15 minutes after feeding. And we recommend that you frequently burp your child during feeding. So if you're breastfeeding, every 5 minutes to help get the air out. If your child is bottle feeding, every ounce or so to help get the air out. If those conservative measures don't work, other things that we may do, depending on kind of the clinical story with your child, we may add medication. Sometimes we use we use a prescription version of the same medicine that adults use over the counter called Zantac or ranitidine. There's no over-the-counter liquid ranitidine for infants, so we need to use prescription ranitidine. But we dose it roughly per pound the same way that it's dosed in adults. That's given twice a day. Sometimes we use more potent acid-blocking medicines, something called proton pump inhibitors, and you'll see advertisements for over-the-counter Prilosec or Prilosec OTC. Again, there are no over-the-counter liquid preparations for children, so we wind up using prescription preparations. We'll use either liquid Prilosec or liquid Prevacid or liquid Nexium, all of which work okay for children as well. The downsides to the proton pump inhibitors is they cause a lot of diarrhea, and they can suppress so much acid that you actually wind up being at risk for infectious diseases of the intestines and stomach. So we try not to over-suppress the acid in the children. In kids with really bad reflux disease, sometimes we will combine the Zantac and the Prevacid. But again, we try really hard not to have to do that. If the acid blockade alone is not working, and that works by tightening up the valve at the top of the stomach. But if the acid blockade's not working, we can add on what are known as prokinetic agents, and those are drugs that help the stomach to empty itself. Because once the food passes from the stomach into the intestine, there is another valve called the pyloric, sorry, I'm drawing a blank here, called the pyloric sphincter. And that valve is very tight, and it's very difficult to reflux past that. So if we can get food out of the stomach, that helps. Those agents, those drugs, go by various names. One of them is metronidazole or once again drawing a blank. One of those is metoclopramide or Reglan, and that one's given 4 times a day. Other times we also will use an antibiotic, specifically erythromycin. This is really the only antibiotic that works for this, but it does help to empty the stomach, and it can be a little less harsh sometimes than the Reglan can be. If the combination of Reglan or erythromycin and Prevacid is not sufficient to stop the reflux and allow the child to grow, then the next step, unfortunately, is surgery. And most people, here in the Western United States anyway, perform a procedure known as Nissen fundoplication, and with that they wrap part of the stomach back around itself and tighten up that valve a little bit. Surgery has its own complications, however. This is a reasonably big abdominal surgery in a little baby. And it makes it very difficult to vomit or to belch, which you don't think much about that as being a good thing, but when you consider that babies in particular swallow a lot of air, if they can't get the air out, they can become distended and very uncomfortable. And that can be a problem with the Nissens. The Nissens involve wrapping the stomach around and then tacking it in place, but those tacking stitches can also come undone, and you can develop what's known as a slip Nissen, and then you wind up having to do the surgery over again. So it's also not the end-all and be-all of the world. The good news is most kids ultimately outgrow this. So what we typically do is we'll place the children on high-dose medication, and we leave them on the medicine until they outgrow it. If as they outgrow or as they grow up and the dose becomes small, the child is having issues, then we'll up the dose again. If as the child gets older, the symptoms don't come back, then we can take them off the medication. So I hope that this has been helpful for you and help you to understand how we're treating this disease for your child. Sorry about the constant telephone interruptions here. Again, if you think your child has gastroesophageal reflux, if we can be of assistance, please give us a call here in our office. and we'll be happy to see your child same day if necessary. Area code 775-359-7111. We'll see you next time.